In the next 12 minutes or so, I'm going to try to convince you that everybody deserves to be in sinus rhythm. Everybody needs an ablation if they're in atrial fibrillation, especially in patients with structural heart disease, especially in patients with valve disease. So what we know is atrial fibrillation is a very progressive phenomenon. It is no one atrial fibrillation. The atrial fibrillation tomorrow is much more advanced than atrial fibrillation yesterday. And this disease keeps getting worse, meaning the progression of atrial myopathy, progression of inflammation, progression of fibrosis in the atria, it just creates a lot of structural changes inside the heart that would allow the atrial fibrillation to continue and cause strokes, heart failure, valvular disease, and other scenarios. There is nothing called asymptomatic atrial fibrillation. The same way I want you to think about AFib, the same way you think about hypertension, the same way you think about diabetes mellitus. There's nothing called asymptomatic atrial fibrillation. In fact, actually, 40% of patients don't have any palpitations, but yet they have heart failure, atrial myopathy, stroke, dementia, accelerated dementia process, kidney problems. So we cannot just leave atrial fibrillation the way it is. Everybody deserves to be in sinus rhythm. This is some data actually from Europe, and they looked at patients who are young patients at 45 years of age, and they just looked at them and see what's the incidence of these patients ended up with structural heart disease, like, for example, heart failure. The risk of developing heart failure in the next 30 years is 35%. Risk of stroke is around 12.5% or 15%. Risk of MI or systemic embolization is 10%. You're talking to about a 45-year-old individual just watching them have all these problems. So in the past, we've had this AFFIRM trial that we looked at whether should everybody be in sinus rhythm. We randomized patients to antiarrhythmic medications versus rate control. We were very discouraged. It did not look like rhythm control strategy did a good job. However, is it because the tools that we were using to get patients back in sinus rhythm bad, or is it that sinus rhythm is bad? When we look at the same analysis of this data, what you find that the use of antiarrhythmic medications was associated with 50% increase in mortality, yet sinus rhythm was associated with 50% decrease in mortality. So what we conclude from this study is not that sinus rhythm is bad, is that we need to find a way to get people back in sinus rhythm that does not involve antiarrhythmic medications. So what options do we have, and what safer options and more effective option we have is clearly atrial fibrillation ablation. Our patient had early AFib or early new onset atrial fibrillation. This is data from the East AFib clinical trial that was done in Germany, and where they looked at patients with early atrial fibrillation and got randomized to either atrial fibrillation ablation or safer antiarrhythmic medications or rate control strategy. Look what you see. Patients who got rhythm control strategy had lower risk of death, cardiovascular mortality, hospitalization from heart failure, or coronary artery disease. So, but let's look at all the data that we have and get all these studies that try to compare rhythm control strategy versus rate control strategy. What you see is the risk of all-cause mortality was lowered by around 25%. Risk of stroke and heart failure hospitalization was pretty much lowered by the same thing. 25% decreased risk of stroke, 25% risk of heart failure. So how am I going to get patients back in sinus rhythm? Is it rhythm control or is it AFib? And the next 8 minutes or so, I'm going to try to convince you that ablation is the way to go. We have plenty of clinical trials that look at paroxysmal atrial fibrillation and try to decide which is a better strategy for these individuals. And when we pull this data, this is some of that done from our institutions, run by our institution, and some from Canada. And what you look at, the success rate of AFib ablation was much better than the success rate of antiarrhythmic medication. Symptoms was much better. Quality of life was much better. Hospitalization was much better. Utilizing healthcare resources was much better with ablation than antiarrhythmic medications. What about this, like this patient with very persistent atrial fibrillation? We see pretty much success rate of antiarrhythmic medication is 10 to 25% and declines significantly with time. After 5 years, barely any antiarrhythmic medication works more than 20%. But even with the persistent bad atrial fibrillation, what you see is that the AFib ablation is way more successful in maintaining sinus rhythm. And if you group all that data, I'm trying to look at mortality now. Do patients live longer with AFib ablation versus antiarrhythmic medication? Guess what? Mortality is better with AFib ablation than antiarrhythmic medication. Developing heart failure is pretty much the same thing. Lower with AFib ablation than antiarrhythmic medication. Morbidities like hospitalization, pretty much the same thing. People live longer and do better and utilize less healthcare resources when you do ablate them or not. What about the risk of stroke? Okay, when we look at the risk of stroke after AFib ablation and compare them to antiarrhythmic medications, what we find is that the stroke, we always underestimate that risk of stroke. A lot of our patients have asymptomatic brain lesions if you do MRI on them or CT scan. And if you try to do a propensity match and try to compare patients who've had AFib ablation versus antiarrhythmic medication, look what you see. This is your risk of stroke to develop with time if you decided on antiarrhythmic medication. With catheter ablation, that's much better. That's almost 30% decrease in risk of stroke if you do ablation over antiarrhythmic medication, even if these patients were on oral anticoagulation. We said our patient had renal dysfunction. Guess what? If you do AFib ablation on these individuals, a lot of times either you stabilize your kidney function or actually the kidney function may get better simply because they get better cardiac output once you try to restore sinus rhythm. What about risk of dementia? We all want to live long, but we all want to live functionally long. We all want to preserve our brain. So let's try to look at this dichotomy here. Which one could decrease the risk of dementia better? Antiarrhythmic medications or ablation? It's clear. It decreases the risk of vascular dementia as well as non-vascular dementia when you compare AFib ablation to antiarrhythmic medication. But that's only if the ablation works. If the ablation doesn't work, it's a sham procedure. But if the ablation works, you cut the risk of dementia by almost 44%. That's very significant. So that's very significant. And why do we think that's the case? Because if you look at patients with atrial fibrillation and compare them to sinus rhythm, and you look at cerebral perfusion, it's clear when they're in sinus rhythm, their cerebral perfusion is much better than when they're on atrial fibrillation. Is this a reversible phenomenon? Meaning, if I can get patients back in sinus rhythm, even for a short period of time, do I improve their cerebral perfusion? This is a study that was very simple. You cardiovert people and you look at their cerebral perfusion after a cardioversion. Does that get better or does not get better? If they do a cardioversion and it failed a cardioversion, look at cerebral perfusion stays the same or worse. If you do a cardioversion and it was successful, look at their cerebral perfusion. It lightens up. And that's what we think why they have less risk of stroke, less risk of emboli, and better perfusion. And what we see with antiarrhythmic medication is we see pretty much the opposite. Actually, cerebral perfusion drops just because of the effect of these medications on the cardiac output, and they get, unfortunately, worse. So, again, there's nothing called asymptomatic atrial fibrillation. We've had a lot of clinical trials that looked at patients and the risk of complications with these procedures. Even if you look at complications between antiarrhythmic medications or AFib ablation, AFib ablation has much lower long-term complications. This patient has clearly AFib functional AV valve regurgitation. So do we have data that if I do something, I would reverse that? It's very simple. If you do AFib ablation and you look at the mitral regurg, left atrial volume shrinks. The amount of mitral regurgitations actually shrink if it was successful AFib ablation. And that's not only limited to the mitral valve, because even if you look at the tricuspid valve, you pretty much see the same thing. You see the tricuspid regurgitant area shrinks, the right atrial appendage is smaller, the right atrial area is smaller. So we see that that valve moves towards the right direction, fortunately. What about patients with systolic and heart failure or preserved of heart failure with preserved ejection fraction? This is Castle AFib when they looked at patients with systolic heart failure. What you see is there is mortality benefit if you restore sinus rhythm in these individuals if they have systolic heart failure. And we see pretty much the same thing with diastolic heart failure. We see that after we get them back in sinus rhythm, they have patients who have diastolic heart failure. You see their BNP gets better. You see the regurgitation get better. You see their E to E prime gets better. Everything moves towards the right directions. And so in summary, everybody deserves to be in sinus rhythm. And what we think is rhythm control is key, and early rhythm control is the key thing. Because the sooner you do AFib ablation and not waste time with antiarrhythmic, the higher success rate of this procedure. And we only try to use rate control strategy only as an absolute last resort. And all of this data is when we have technology that was associated with higher risk. Now, we have much better technology called pulse field ablation that can get the patients back in sinus rhythm with slightly higher success rate, but more importantly, a much safer strategy, less risk of complications. It is a shorter procedure, so if you're worried about your patients who are very sick and you don't want to put them to sleep for a long period of time, it is more efficient procedure, and it's a much safer procedure where the risk of PV stenosis or collateral damage is almost zero. So what's the future? The future is now. Early detection, early ablation, use safer strategy, and try to coordinate with your colleagues in the imaging department in heart failure, trying to optimize care for these individuals, because this is the AFib team at the Cleveland Clinic. You have everybody involved. And that's the way we try to look at that. And with that, thank you.